Good morning everyone. I am Dr. ANAKHA E S. Today I will be leading the discussion with section 6 of our reading club based on Misch Contemporary Implant Dentistry, which is being conducted in connection with the International Implant Summit in 2026. We will begin with the chapter 32, Immediate Implant Surgical Protocol. The traditional dental implant placement protocol is a proven and reliable treatment modality to restore edentulous spaces. However, a healing period is usually required after extraction and/or graft, which delays the implant placement and ultimately the placement of the final prosthesis. This extended treatment time leaves the patient without teeth and usually an inner rim prosthesis. The objectives of immediate implant placement are the same as for conventional stage treatment. Implant primary stability, sufficient rigid fixation after healing, ideal positioning for implant restoration, and an ideal aesthetic result. Immediate implant placement has become extremely popular because these objectives can be obtained with fewer procedures, less treatment time, and less cost to the patient. Implant placement definitions. Immediate at the time of extraction, early 4 to 6 weeks after extraction, delayed 3 to 4 months after extraction, and late greater than 4 months after tooth extraction. Advantages of immediate placement: decreased treatment time and cost, decreased need for bone augmentation, preservation of the soft tissue drape, improved implant positioning, high patient satisfaction. Consequences of implant failure. If implant failure results from an immediate implant, significant complications may occur. Usually, the need for bone augmentation will result, which delays treatment and increases cost. Studies have shown that a replacement implant has a success rate of approximately 71% and a third replacement has a success rate of approximately 60%. Therefore, implant failure may lead to many financial and patient-related issues. Disadvantages of immediate placement: site morphology, surgical technique is more complicated, anatomic limitations, lack of primary closure, presence of acute or chronic pathology, consequences of implant failure. Aesthetic risk, especially in the anterior region, extracting a tooth with the immediate implant placement may result in non-ideal aesthetic issues. Therefore, the patient should be evaluated preoperatively for the following aesthetic parameters: lip line in relation to the teeth and gingival margins, presence and position of interproximal papilla, shape and shade of adjacent teeth, presence of restoration on adjacent teeth, and a hard and soft tissue thickness analysis. In some cases, even with an ideal aesthetic result, possible limitations may deem the placement of implants non-ideal. Requirements for immediate implant placement. A CBCT evaluation confirms sufficient bone quantity. In addition, sufficient proximal bone to avoid encroachment on adjacent roots. An aesthetic risk evaluation should be completed before immediate implant placement. The following factors should be taken into consideration, that is, smile line, soft tissue drape, adjacent teeth shade stable and free of large restorations. Ability to position implant in an ideal location for prosthetic rehabilitation, which is dependent on anatomic location and the available bone. Ideal primary implant stability is achieved, which is dictated by bone density, surgical technique, and implant design. If any of the above requirements are not satisfactory, the clinician should be determined if other treatment options exist. Immediate implant placement technique. Step 1. Clinical and radiographic examination. The type of extraction defect may be anticipated with a careful pre-operative clinical examination that includes periodontal probing, evaluation of mobility, infection and fractures along with 2 and 3 dimensional radiographs. Step 2. Atraumatic tooth extraction. The atraumatic extraction of a natural tooth should ideally begin with a sulcular incision, preferably with a thin scalpel blade or periotome 360 degrees around the tooth. This will ensure all connective tissue attachment fibers above the bone level are severed. Failure to cut these fibers before extraction will result in increased tissue trauma and possible fracture of buccal plate of bone. For an atraumatic extraction, the less soft tissue reflection, the better as to minimize disruption of the blood supply. Periotomes and dental elevators, which both use the mechanical advantage of a wedge, can then be used to initiate the luxation of teeth for their removal. A traditional dental forceps is used to grasp the tooth for any needed additional luxation before tooth removal. Ideally, forceps should not be used until mobility of tooth is present. Step 3. Curating the extraction socket. The debridement of the extraction socket is imperative in the immediate implant process. Any remnants of periodontal ligament, bacteria, residual infection, dental material and tooth fragments may affect the osseointegration process. Step 4. Evaluating the extraction socket for remaining walls. The easiest and simplest technique for evaluating the remaining walls of bone after an extraction is with a blunted probe. The index finger may be placed over the buccal plate of bone and the probe is then introduced into the socket and run up and down within the socket. Step 5. Immediate implant placement technique. Flap design. 3 types of flap designs are used for immediate implants. Open, that is buccal and lingual tissue reflected. Minimal flap, no buccal or lingual reflection but minimal flap to expose crustal area, or flapless, that is tissue punch. Canva et al. Evaluated flap versus flapless implant placement into extraction sockets and determined there is no difference in the bone loss between the two techniques. Implant osteotomy. The immediate implant placement surgical technique is initiated with either a surgical template or freehand technique. A surgical template. If a surgical template is used, it should be placed over the adjacent teeth, that is ideally tooth supported, and standard drilling procedures completed according to the manufacturer's instructions, that is pilot, universal, fully guided surgical templates. Freehand. The initial osteotomy is directly related to the anatomic area and remaining socket anatomy. For example, in the maxillary anterior region, it is crucial to avoid placing the implant directly in the center of the extraction socket. Placement of the implant in this position may perforate the buccal plate and increase morbidity. Ideal positioning, ideal depth. In general, it has been accepted in the literature that 2 to 4 mm of bone is ideally required apical to the inferior part of the socket to obtain primary stability for an immediate implant. Madani et al. Reported in a retrospective study that immediate implant placement 1.08 mm subcrustally is the ideal depth of the neck of the implant. Subcrustal placement of the implant greater than 2 mm led to an increased bone loss. The vertical position of the implant shoulder should be 1 mm apical to the buccal crust to allow for adequate space for an emergence profile of the final restoration. Jumping distance or maxillary anterior. The horizontal bone defect or jumping distance or gap is defined as the distance between the implant and the surrounding wall of the defect. Multiple animal and human studies have shown that the gap will fill with bone regardless of whether graft materials and barriers are used. Botticelli et al. Reported that in defects of 2 mm or larger, no grafting was needed to grow bone. Tarnow et al. Concluded that as long as the buccal plate is intact after the extraction, no bone graft, membrane or primary closure is needed regardless of how large the defect is. In most cases, care should be exercised not to completely fill the extraction socket with the implant. Many studies have shown conflicting results with the aftermath of filling the void between the implant and buccal socket wall. In author's opinion, the gap should always be grafting with a bone substitute that will maintain the space long enough for bone to regenerate, which ultimately will maintain the hard and soft tissue. Therefore, a slower resorbing material, that is mineralized freeze-dried bone graft or xenograft, not a faster resorbing material, that is demineralized freeze-dried bone and autograft, should be used to augment the graft. Minimum torque. To achieve primary stability, a minimum torque value has been shown to be one of the most important factors in the success of immediate implants. The minimum torque has been shown to be approximately 35 to 45 Newton per centimeter in the literature. Implant stability. The initial stability of the immediate implant is one of the most critical factors in the success of implant. When micro movement occurs, implant bone interface is reduced, thereby resulting in loss of primary stability. Micro movement greater than 100 micrometer may cause fibrous encapsulation of the implant. There exists two types of implant stability, primary and secondary. Primary stability is defined as the stability of the dental implant immediately after placement. It is derived from mechanical friction of the implant threads and the surrounding bone. Several methods have been advocated in the literature to determine primary stability. Percussion is the first test method in the literature to be used to assess the primary stability and estimate the amount of bone implant contact. This technique is based on vibrational acoustic signs where a high-pitched sound signifies integration and a low-pitched sound may be indicative of lack of integration. Unfortunately, this test is highly dependent on clinicians' experience level and subjective beliefs. Therefore, although still used, it is not the most ideal testing method. Perio test is a testing method that has been proposed to be a more objective method for assessment of implant stability. Although much better than percussion test, the Perio test has been shown to have inaccuracies in the lack of resolution, poor sensitivity and subject to operator's variability. See, a more recent method is the use of insertion torque that can be measured with low-speed insertion tools, that is surgical handpiece or manual wrench ratchet. It has been shown that for a successful immediate loading protocol, the insertion torque should be between 35 and 45 Newton per centimeter. D. Resonance frequency analysis is a diagnostic tool that allows for detecting implant stability as a function of the stiffness of bone implant interface. This test can be used in a continuous and objective manner during healing phases of the implant. RFA was initially presented by Meredith et al. In 1996. RFA has been shown to have quantitative and reproducible measurements on the presence of integration, immediate load feasibility and follow-up evaluation at the prediction of an implant failure. RFA is a technique that is based on continual excitation of implant interface through the use of dynamic vibration analysis or piezo effect. A specialized transducer which contains two piezoceramic elements is either attached directly to the implant or abutment. The first piezo element generates an excitation signal that is sinusoidal wave at a 5 to 15 kHz, leading to vibration of a whole transducer implant tissue complex. The oscillation response is measured by second piezo element. RFA technique measures implant stability as a function of stiffness of the bone implant complex. The health of the implant is measured on an implant stability quotient, that is ISQ, that is calculated on a scale from 1 to 100. The full integration of an implant is usually measured in the range from 45 to 85 ISQ. Measurements of less than 45 are indicative of implant failure, whereas ISQ value of 60 to 70 indicates success. Moving on to conclusion. Placement of immediate implants into an extraction sites have been shown through the literature to be very successful. Technological advances have led to an array of options for the patient and clinician as an alternative to the traditional two-stage technique. Immediate placement implants pose many challenges to clinicians, especially when treating patients with pre-existing hard and soft tissue deficiencies. In this chapter, the advantages and disadvantages of immediate implants were explained in detail along with numerous treatment planning factors that should be ideally evaluated prior to treatment. With appropriate patient selection and treatment planning, complications may be minimized and success rates increase with immediate placement implants. In addition, each specific tooth position is discussed in detail with a treatment planning protocol which allows the clinician to understand when ideal conditions exist. cautious variables are present, and when immediate placement is contraindicated. Now we are moving on to Chapter 33, Immediate Load or Restoration in Implant Dentistry. For years, the two-stage surgical protocol established by Brainmark et al. To accomplish osseointegration was considered as a prerequisite for achieving osseointegration and long-term success. This traditional surgical protocol consisted of placing dental implants slightly below the crestal bone, obtaining and maintaining a soft tissue covering over the implant, and allowing for a non-loaded implant environment for 3 to 6 months. The success of the two-stage technique was highly documented. However, many in the field still strive for shorter treatment times and fewer surgical interventions. With advances in implant technology, the traditional protocol in implant dentistry has been re-evaluated, which has led to a growing interest in the immediate loading protocol. An abundance of clinical studies have shown positive outcomes and success with loading implants immediately or within a shorter period after implant placement. Immediate loading terminology. The concept of immediate loading implants involves a non-submerged first-stage surgery with the immediate loading of implants with an interim or final prosthesis. The terminology and nomenclature for these techniques are poorly understood with little consistency. Therefore, in an attempt to standardize the language in which immediate loading is discussed, Misch et al. Suggested a terminology for immediate restoration and or occlusal loading. Immediate load or function definitions. Immediate occlusal loading. Insertion of an implant-supported interim prosthesis or final restoration in occlusal contact within 2 weeks of implant insertion. Early occlusal loading refers to an implant-supported prosthesis in occlusion between 2 weeks and 3 months after implant placement, that is, occlusal loading implants after a short healing period approximately 5 weeks. Delayed or staged occlusal loading. An implant prosthesis with an occlusal load after more than 3 months after implant insertion. The delayed occlusal loading approach may use either a two-stage surgical procedure that covers the implant with a soft tissue or a one-stage approach that exposes the implant with a healing abutment. Non-functional immediate prosthesis. This describes an implant prosthesis with no direct occlusal load within 2 weeks of implant insertion and is primarily considered in partially edentulous patients, that is, congenitally missing maxillary lateral incisor. Non-functional early prosthesis describes a prosthesis delivered between 2 weeks and 3 months after implant insertion. Occlusal loading. The prosthesis is in contact with the opposing dentition in centric occlusion. Non-occlusal loading. The prosthesis is not in contact with the centric occlusion with the opposing dentition in the natural jaw position. Provisional prosthesis. A fixed or removable dental prosthesis designed to enhance aesthetics, stabilization and or function for a limited period, after which it is to be replaced by a definitive dental prosthesis. This type of prosthesis assists in the determination of the therapeutic effectiveness of a specific treatment plan or the form and function. Disadvantages of immediate load implants. Increased skill level required, especially when extracting teeth and placing implants at the same time. An increased skill level is required. These type of cases require significant pre-planning, most commonly with advanced cone beam computed tomography or CBCT interactive treatment planning. In addition, CBCT bone reduction and placement guides may be indicated, which increases the complexity of the surgery and prosthetic protocols. Initial surgical or prosthetic appointment longer. In some cases, the surgical placement of implants and the prosthetic procedures may require a longer appointment duration than normal. This may lead to increase exceeding the patient's tolerance for appointment length. With some patients, this may predispose them to an increased possibility of medical complications. Possible increased implant mobility. An often talked about disadvantage for the immediate load concept is the risk for implant bone loss or implant failure. In general, this is not supported by clinical studies and research. Shen et al. In a systematic review and meta-analysis compared immediate loaded implants versus conventional loading and found no difference in marginal bone loss between the two techniques. However, if failure does occur, this will often lead to patients' loss of confidence in doctor, increased cost and treatment time together with a longer treatment period. Prerequisites for immediate loading protocol. For the immediate loading protocol to be successful, various treatment planning and patient factors need to be taken into consideration, implemented in the patient's treatment. Adequate bone density. Ideally, the bone density should be favorable for an immediate loaded prosthesis, approximately D1, D2, D3. However, in some cases of poor bone quality, even with modified surgical protocols, achieving an insertion torque greater than 35 Nm is unachievable. In these clinical situations, the immediate loading protocol is not recommended and a healing period of 4 to 6 months is suggested before loading the dental implants. In addition, the prosthetic rehabilitation should include a progressive bone loading protocol which increases bone density around the implants. Sufficient bone dimensions. For immediate load cases, it is imperative that sufficient height and width of bone are available for placement of implants. Lazara et al. Stated that 12 mm of available bone height is recommended and 6 mm of available bone width is required for adequate support. In clinical cases of compromised bone quantity, immediate loaded implants may be at higher risk for bone loss or failure. Therefore, more implants or implants with a greater surface area are recommended. Ideal insertion torque. In the literature, it is generally accepted that the immediate loading concept is based on obtaining an insertion torque of greater than 35 Nm to provide sufficient implant stability when the prosthesis is placed under loading situations. However, studies have shown successful implant integration at insertion torques of 30 Nm or less. Mallow et al. Stated that implants inserted with less than 30 Nm of torque in an all-on-4 protocol have similar short-term success outcomes and marginal bone loss compared with implants inserted with greater than or equal to 30 Nm of torque. Histologic evaluation of immediate loaded implants. Long-term evaluation. Piatelli et al. Evaluated bone reactions and bone and titanium interface in early loaded implants in monkeys, compared with unloaded implants in the same arch several months after immediate loading. No statistically significant differences were detected in the BIC after 8 months. No fibrous tissue was found at the interface. After 15 months, unloaded and immediately loaded implants were compared and loaded implants exhibited greater or almost twice direct bone contact at the interface. In particular, early loaded screws demonstrated thicker lamellar and cortical bone than unloaded implants. These findings suggest that early occlusal loading may enhance bone remodeling and further increase bone density. Rando et al. Evaluated the bone interface in a human patient after 18 months in an immediate loading situation. They noted a direct blown implant interface. Lenderman confirmed these results in a 95-year-old patient who had an immediate loaded ball-connected overdenture in function for 12 years. Thus, a long-lasting direct BIC relationship appears to be possible. Immediate occlusal loading. Factors that decrease risks. Bone microstrain. One method to decrease microstrain and the remodeling rate in bone is to provide conditions that increase functional surface area to the implant bone interface. The surface area of load may be increased in number of ways: implant number, implant size, implant design, and implant body surface conditions. The force to the prosthesis also is related to the strain and may be altered in magnitude, duration, direction, or type. Methods that affect the amount of force include patient's condition, implant position, and direction of occlusal load. Increase surface area. Implant number. In numerous studies, 10 to 13 implants were inserted and spindled together per arch, and implant survival rate may be greater than 97%. The increased number of implants also increases the retention of the restoration and reduces the number of pondings. The increased retention minimizes the occurrence of partially unretained restorations during healing, which can overload the implant, still supporting the restoration. Implant size. The surface area may also be increased by the size of the implant. Each 3 mm increase in length can improve surface area support by more than 20%. The benefit of increased length is not found at the crustal bone interface, but rather in initial stability of bone implant interface. Implant body design. A few clinical trials have compared immediate loading with different implant thread designs and tapered implant bodies in the completely edentulous patient. The short-term clinical reports indicate a high success rate regardless of implant design. As a result, overall shape and thread geometry apparently may not be the most important aspects for immediate occlusal load survival. Implant number, implant position, and patient factors most likely are more relevant components of success. Future studies in this area are certainly needed. Indications. Edentulous areas with favorable available bone and bone density. Partially edentulous patients with centric occlusal contacts and exertions on natural teeth. No parafunctional habits. Ideal implant position and implant dimensions. Contraindications. Patients with parafunctional oral habits, that is, anterior and lateral tongue thrust or biting on a pipe while smoking. Occlusal contacts that would result in functional contacts or implant prosthesis. Advantages of non-functional immediate teeth. Patient has a fixed aesthetic tooth replacement after stage 1 surgery. No stage 2 surgery is necessary. Eliminate discomfort for the patient and decrease overhead for the doctor. The soft tissue emergence may be developed with the transitional prosthesis and the tissue allowed to mature during the bone healing process. The soft tissue hemidesmosome attachment on the implant body below the microgap connection may heal with an improved interface. The patient is able to evaluate the aesthetics of provisional prosthesis during the healing phase. Disadvantages of non-functional immediate teeth. If force is applied to the provisional prosthesis, micro-movement of the implant may cause crustal bone loss or implant failure. Parafunction from tongue or foreign habits, that is pen biting, may cause trauma and crustal bone loss or implant failure. Impression material or acrylic may become trapped under tissue or between the implant and crustal bone. Bone that is too soft, small implant diameters or implant designs with less surface area may cause too great crustal stress contours and cause bone loss or implant failures. The duration of surgery and or post-operative appointment is longer. Literature review of partially edentulous arches. Early loading in partially edentulous arch. Testori et al. Reported on a third year 97.7% success rate in a longitudinal prospective multi-center study of early implant loading. All implants were placed in posterior region of the oral cavity and were loaded within 8 weeks. Cochrane et al. In a longitudinal prospective multi-center study reported a 99.1% success rate after 1 year. Immediate loading in partially edentulous arch. Drago and Lazara related a study involving restored fixed provisional implant crowns without occlusion immediately after implant placement. The implants were immediately restored with prefabricated stock abutments and cement retained. No occlusal contacts or interferences were present. Final prostheses were inserted 8 to 12 weeks after implant placement. After 18 months, the implant survival rate was 97.4% and an average bone loss of 0.76 mm was reported. Provisional implants. The use of provisional implants, which are defined as the implants placed to retain an interim prosthesis, are not necessarily indicated for a permanent prosthesis. Originally, these implants were thought not to achieve osseointegration. However, Balkin et al. Evaluated mini implants for light microscopy evaluation after 4 to 5 months of immediate function. They reported that OC integration did occur with mature and healthy bone. Leslie et al. Reported on 3 provisional implants that were placed to retain a provisional prosthesis for 4 months. They concluded the existence of bone trabeculae around the implants as well as the occurrence of the bone remodeling process. All on for surgical or prosthetic protocol. Mallow et al. Originally introduced the concept of the all-on-4 protocol, which involves the immediate loading of a fixed prosthesis on 4 implants placed in the maxilla or mandible. Although numerous options are available, in general, 2 parallel implants are placed anteriorly and 2 angled implants are placed posteriorly. The posterior implants are accurately positioned to avoid key vital structures, example maxillary sinus, inferior alveolar canal, increase AP spread, and minimize cantilever length. Because of these positioning protocols, a significant treatment time savings is seen as sinus augmentation and bone grafting procedures in mandible are avoided. Usually in the maxilla, 2 posterior implants are positioned at up to 45 degrees of angulation to avoid maxillary sinus. In the mandible, the position of the implant is dictated by the Mendel-Foramen position, that is, possible anterior loop. However, they are usually angulated anteriorly 30 to 45 degrees. Multi-unit abutments are placed into the implants with varying degrees of angulation, usually consisting of 0, 17 or 30 degrees. Requirements of the all-on-4 technique. Minimum of 35 Newton-centimeter insertion torque. If this cannot be achieved, then a conventional healing phase is recommended. No significant parafunction habits. Available bone dimensions. Maxilla greater than 5 mm of width and greater than 10 mm of height. Mandible greater than 5 mm of width and greater than 8 mm of height. Favorable bone density of D1, D2 and D3. The all-on-4 treatment may be performed with 2 approaches. First is conventional surgery. Full thickness flap and freehand implant placement. After flap elevation, a midline osteotomy is completed in which all-on-4 guide is placed. B. Posterior surgical osteotomy. The posterior sides are prepared at approximately 45 degrees using the guide as an angulation tool. Implants are inserted at a final torque of 35 to 45 Newton-centimeter. 30 degree multi-unit abutments are placed into both posterior sides. The abutments are tightened to the manufacturer's recommendations. C. Anterior surgical osteotomy. Prepare and place 2 anterior implants in the approximate B and D positions. Implants are inserted at a final torque of 35 to 45 Newton-centimeter. Multi-unit abutments are placed into both anterior sides. The abutments are tightened to the manufacturer's recommendations. Guided, tissue or bone supported guide. Implant placement. 4 implants are placed according to the type of guide. Tissue supported, flapless or bone supported. Flap is raised to expose the residual ridge. The 4 implants are placed according to the interactive CBCT treatment plan. Note, the angulation of posterior implants is dictated by anatomic landmarks evaluated on 3D CBCT. Prosthetic procedure. Temporary multi-unit abutment copings are placed on each implant and hand tightened. The fabricated prosthesis is tried in to verify proper fitting and occlusion. Lightweight composite or acrylic is used to fixate the interim prosthesis to temporary abutments. The prosthesis is removed and any voids present between the abutments and prosthesis are filled with composite or acrylic. The prosthesis is polished and reinserted for final insertion. The abutment screws are placed with a final torque as per the manufacturer's recommendations. Polytetrafluoroethylene PTFE tape is placed in the access holes and light cured composite or acrylic is used to cover the holes. Summary. The majority of clinical reports reveal similar survival rates between immediate loaded and 2-stage unloaded healing approaches in the completely edentulous patient. Nonetheless, these findings do not imply that a submerged surgical protocol is no longer necessary or prudent in many cases. Future studies may find indications based on surgical, host, implant and occlusal conditions more beneficial for one versus the other. For example, the strength of bone and the modulus of elasticity are related directly to bone density. The softest bone type may be 10 times weaker than the densest type. The microstrain mismatch of titanium and the softest bone is much greater than the densest bone. As a result, higher implant failure and greater crustal bone loss seems likely but as yet are not reported in the literature. The biomechanical treatment approach to increase surface area and decrease forces applied to the immediate restorations is most likely the major reason for the high implant survival. Thank you for listening.